Okay, thank you all very much. I'm Richard Oehler, Associate Professor here at USF, and today I'm going to be talking about brucellosis. So, brucellosis, obviously, chiefly a zoonotic infection associated um, with agriculture and more of an issue in the third world. Um, to say I'm an expert in brucellosis would be not true. This is not a widely seen infection in, oftentimes in developed countries, more of an issue in typically in underdeveloped countries, but sometimes in developed countries as well. So to start it out, this is a stamp, I believe, from Malta, and it highlights the discovery and development of the care of brucellosis. So does anyone know how these two individuals are important to the history of brucellosis? You have Dr. Bruce and Dr. Zammit. Well, I'm going to tell you. So Sir David Bruce, who died in 1931, was an Australian physician who was medically trained in Scotland. And while he was in Malta, he studied the syndrome of what was known as Malta fever. And initially it was identified as Micrococcus melitensis, but it was later, because of a lot of the work that he did, renamed in his honor to Brucellosis melitensis. And a later Maltese public health clinician, Themistocles Zammit, discovered the association with goats. So those are your two titans of brucellosis, Dr. Bruce and Dr. Zammit. So brucellosis goes by a variety of different names. It's called Bang's disease, Crimean fever, Malta fever because of its predisposition to that country, Mediterranean fever, and also undulant fever, which it's gained because of some characteristics of the febrile response in patients. And predominantly it's transmitted to humans by fluids from infected animals, typically livestock like predominantly sheep, goats, but also cattle and pigs. And because of our reliance on agriculture and food products from livestock, it naturally also can be transmitted through foodstuffs. It affects not just humans but also animals as well. And as I said, it's predominant in developing countries. But because of greater international travel, migration, and commerce, because we get so much of our food from other countries, we can also see it as a result of the highly industrialized food industry. So, in fact, human brucellosis due to Brucella melitensis is the most common zoonosis worldwide. And you're going to see it a lot in the Mediterranean basin, the Arabian Gulf, parts of the Indian subcontinent, but also in this hemisphere, it's also common in Mexico and parts of Central and South America. If you're an infected animal, you can excrete brucella in a wide variety of secretions from urine and milk, the placenta, and so forth. When animals miscarry as well, you can get products of miscarriages that are infected with brucella. For instance, this is a picture I found on the internet of brucellosis in a caribou's knee. This is indicative of the skeletal manifestations of brucellosis. Looks like a basketball, doesn't it? Now, as I said, brucella is not terribly common in this country, but you can think of its geographic distribution in terms of stripes. I call the Pacific stripe the prevalence of brucellosis in the state of Washington and California. Again, remember, they have predominant agricultural industry. But then you have the stripe that goes across the Midwestern U.S., Texas, the Midwestern states, parts of Colorado, Idaho, Montana, and so forth. And then you have this stripe that goes down the eastern U.S. along the Atlantic coast, from New York down to the Carolinas, and then including the state of Florida. And note there are some areas of the western U.S. like Nevada, for example, the central South U.S., where brucellosis is much less common. So you can get brucellosis as a human person in several different ways. The two predominant ways you can be infected with brucellosis is ingestion of products from contaminated animals. And insufficiently cooked or raw meat is common, but also unpasteurized milk and cheese, particularly soft cheeses. But you can also get brucellosis through skin lesions, the conjunctivae, and from inhaling contaminated dust or aerosols, leading to Brucella lung disease. Occupational exposure to brucellosis is also possible, not just in the agricultural industry, but also among laboratory workers. And for this reason, it's recommended if you ever suspect Brucella that you inform your laboratory very promptly. There's some miscellaneous ways that you can get brucellosis. Blood transfusion, tissue transplantation is possible, also through breastfeeding. It can be a sexually transmitted disease, congenitally acquired as well, and nosocomial infection also occasionally occurs. But remember for your boards that person-to-person transmission of Brucella is unusual and unlikely. So this is a gram stain of Brucella, and you can see that they are gram-negative, usually described as coccobacillary, and they're non-modal, facultative intercellular gram-negative rods on gram stain that look like coccobacilli. And in fact, they're very, very tiny, and they're described as the smallest gram-negative organism seen in the microlab other than Francisella tularensis. They grow slowly on blood and chocolate agar, but not on McConkey. So, you know, if you do a McConkey plate for gastrointestinal pathogens, you're not going to grow Brucella. And they tend to survive particularly long in frozen meat and goat cheese, up to 3 months in goat cheese. So those of you who are feta fans, looking in the back here, be advised if you have unpasteurized goat cheese, Brucella is a risk. So how does brucellosis cause disease? Well, Brucella is actually an intracellular pathogen, but it doesn't have any classical virulence factors, so it's not a disease where you get intense inflammatory cascade, and that's why it tends to develop rather insidiously. And it's been noted that interferon gamma and the cell-mediated immune response is important to host defense. You don't get a lot of humoral antibody production as part of the host response, except that that's useful for diagnosis. There's typically a prolonged incubation period up to 1 to 4 weeks, but sometimes in insidious cases, you can get an incubation period that can be months long. For example, you see patients with the insidious onset of osteoarticular disease, for example. And it's important to remember that Brucella melitensis is the most virulent of the species, followed by abortus, suis, and canis. The two most common presentations are acute febrile illness, where someone mounts a fever, they're ill-appearing, and then you have those patients who have chronic infection. And acute febrile illness can present with both a localized infection specific to a common body region, or you can have non-localized disease manifesting as an FUO. And adults typically are more severely infected and have a poor response to treatment than kids. So when there is more of an insidious onset, you have more prolonged incubation period, what you typically see is an FUO, typically fever, night sweats, and the sweats are described as having kind of a moldy odor. So if you detect that in your patients with an FUO, think about brucellosis. And you can get more systemic manifestations like arthralgias, myalgias, weight loss and weakness, headache, dizziness. I've listed some of these on the slide. The fever is not extremely high. It's slightly elevated to high, but it has an irregular undulation, and that's why the term undulant fever is used. And about 30% of cases present with a localized infection. So here's an example of undulant fever where you see that there's this variability of fever that you might see with other febrile illnesses, but you have this sort of waxing and waning pattern. And notice that that can occur over, in this case, over 30 days in somebody with a chronic infection. And the clinical manifestations of brucellosis can affect many different organ systems. For example, in the ocular system, you can have someone present with an endophthalmitis. Pulmonary disease can present with bronchopneumonia, not with pulmonary nodules. Gastrointestinal disease, you can have a Brucella hepatitis, for example, or a primary bacterial peritonitis. Cutaneous disease can include skin abscesses, skin lesions, or even erythema nodosum. The central nervous system, think about Brucella meningitis or encephalitis. Endocarditis disease is possible in the cardiovascular system. Genitourinary disease can present with an epididymoorchitis or a glomerulonephritis. And we know the skeletal manifestations of the disease. I'll touch more on these in just a second. So talking about the osteoarticular involvement of Brucella in localized infections, think about the sacroiliac joints and the large joints of the lower extremities. If you see here, I have a bone scan showing a sacroiliitis in a patient with brucellosis. Spondylitis can commonly occur, and that can be paravertebral, epidural. You can have psoas abscesses. So think about brucellosis in someone with a psoas abscess. And remember that it's not easy to suspect this unless you take a good history and you ask about a food history, a employment history. Maybe someone is making undercooked meat or jerky as a hobby, and they are exposed to Brucella. Maybe someone has recently visited Lebanon and has had meat made from a private kitchen, and who knows?
You gifts.
Right, and you get gifts from your relatives, exactly. So remember Brucella orchitis or epididymitis. That can occur in 10 to 20% of cases. And for pulmonary disease, remember that some Brucella can be inhaled. Think about an interstitial pneumonitis, a lobar pneumonia. Think about lung nodules being due to brucellosis, empyema or abscesses. And clinical hepatitis can occasionally occur. This is a hepatic tissue with a granuloma due to brucellosis. So here's a patient described in a Spanish medical journal, or maybe it's a Spanish case in a English medical journal, of bilateral pulmonary nodules. That says due to tuberculosis. I'm sure that's a typo on my part. This is really due to brucellosis, forgive me. And you can see on the left, the patient has several rather prominent nodules, and with a sort of a hypoattenuated central area, and these are due to Brucella disease, disseminated brucellosis in this patient. Again, forgive the typo. This is a Brucella spondylitis, and you can see the areas of destruction there in the central portion of the picture, and then also on the right here in cross section. And so think about Brucella spondylitis, and this may present more with a chronic picture in someone with chronic back pain. And diagnosis, of course, would require either biopsy of the involved tissue, perhaps serology, and also a good clinical suspicion that someone was at risk. These are more localized infections. Remember that hematologic manifestations are possible. You might find someone with anemia, leukopenia, or pancytopenia. Neurologic complications, in addition to meningitis and encephalitis that I spoke about before, you can have a myelitis and a radiculitis. Endocarditis is a predominant cause of death in patients with brucellosis. So a lot of patients who die from brucellosis have endocarditis as a complication. But you can have a wide variety of other manifestations, including myocarditis or pericarditis, and myoclonic aneurysms have also been described. Dermatologic disease can be very diverse, from flat and raised eruptions to ulcerations to granulomatous vasculitis and even abscesses. So this is a person with a skin lesion due to brucellosis. Again, whether this patient acquired it through direct contact or whether this is a systemic, more of a systemic manifestation is less clear. Another thing with brucellosis you can get is relapses. Relapses can occur in up to 15% of cases. And a lot of times this is due to inadequate antibiotic choice, maybe someone who's not well adherent, because remember, this requires prolonged treatment. And there can also be a localized focus maybe that's inadequately debrided. Let's say, for example, someone with a spondylitis who's not properly debrided, maybe who's an inadequate combination of agents and who therefore has a relapse. And unlike perhaps some other conditions, you can be reinfected with brucellosis, so you can have it more than once. So if you get multiple gifts from your relatives or friends, you can become reinfected. And when chronic brucellosis occurs, it's typically associated with a localized focus, as I said before. Maybe someone has an osteomyelitis that's inadequately debrided, and so they develop more of a chronic infection. Now, what about diagnosis of brucellosis? You can diagnose brucellosis in several ways: via culture, via serology, or via PCR. But there are caveats regarding the use of each of these different modalities. And any culture needs to be interpreted in the context of what clinical history you get, what their exposure history is, and whether they've been infected in the past. Because remember, someone who's been infected in the past may have positive serology, and what do you do with that? I think that's probably 10. When cultures are obtained, they're most helpful from bone marrow usually, but blood cultures may also be positive, and sometimes you can isolate the organism from hepatic tissue. Routine studies are not always helpful. They're usually non-specific. If someone has an anemia or a pancytopenia, that obviously doesn't point just to brucellosis. It could be due to other causes. And sometimes radiographs are helpful. For example, if you do CT or MRI imaging of the spine in the setting of bone disease, or if you see someone with large pulmonary nodules, as we saw here, who may be at risk for brucellosis. And also echocardiograms in the case of patients where you may suspect endocarditis. So what's the problem with cultures for diagnosing brucellosis? Well, obviously, if you culture brucella from the blood or from infected tissue, you have a slam dunk, right? You can say that they have brucellosis. But cultures are time-consuming. They're not always very sensitive. You tend to have the need for a higher inoculum of organisms to detect them on culture. And also, if you try to culture up in the lab, you place your lab workers at significant risk if they don't have appropriate precautions. There are two major culture mechanisms or methods useful in third world countries, like they call one of them the Ruiz-Castaneda method, and versus lysis centrifugation. Lysis centrifugation is the more sensitive of the two. And actually, if you have semi-automatic methods, and in the reference source I used, they mentioned the BACTEC and BAC alert systems, they actually may be somewhat more sensitive than the manual methods. So this is one area where automated blood culture systems actually work better in some cases than the manual methods. Up to 70% of cases can have positive cultures. So culturing Brucella is definitely a diagnostic modality that you want to consider. Now remember, with Brucella, as is the case with other infectious diseases that have detectable antibody titers, acute and convalescent serology is much more sensitive than just single serology methods. And so the serology diagnostic method of choice is called the SAT, or the serum agglutination testing, and you want to see a fourfold rise in titers from acute to convalescent sera. And sometimes the prozone phenomenon can affect Brucella titers, so you have to be aware of that. There are other titers that are also useful in relapsing brucellosis and those with persistent active infection. But remember that serology cross-reacts with other pathogens as well. So you may get cross-reaction in someone with tularemia, with Yersinia, and the others listed here. Unfortunately, a PCR test is not standardized, is not widely available. So you're not going to have a lot of luck with Brucella PCR, but it's always a good idea to check with the CDC to see what detection methods they have available. So let's move on here to treatment. So what are the principles of treatment of brucellosis? First of all, you want to control illness and you want to prevent complications, right? If you don't treat Brucella adequately, and remember this is one of those conditions that requires a prolonged course of treatment, they can be complicated by worsening of their disease, maybe localized disease or chronic brucellosis. You want to use antibiotic therapies that are useful, that are helpful in the intracellular compartment, because remember this is a tiny coccobacilli that likes the intracellular compartment. And this is a disease that you want to use combination therapy. Monotherapy for Brucella is contraindicated and ill-advised, and you have to treat for a prolonged course. So when you treat brucellosis, you want to consider whether it's uncomplicated disease or whether it's more focal disease, which tends to be more complicated. So how do you treat uncomplicated disease? Well, first of all, uncomplicated disease is brucellosis generally without focal findings like spondylitis or Brucella of the central nervous system or endocarditis. So if you don't have either of those things, you don't have neurological disease, cardiac disease, or bone disease, it's generally considered uncomplicated. So for those particular cases, you can use generally 2 drugs for the first 2 to 3 weeks, generally with one of them being a parenteral agent, and then you can consider the use of other oral agents as well, like doxy or rifampin in some cases. As I said, monotherapy is not acceptable, and sometimes you can use fluoroquinolones as an alternative second-line therapy in combination with the other agents. Now, when you use parenteral therapy like doxycycline plus streptomycin, you can also consider gentamicin as a substitute. So, so most people, if it's uncomplicated disease and you don't need to use a parenteral agent, will use doxycycline plus rifampin. That's a combination that tends to work well. Again, you don't involve the aminoglycoside, and there's a lower risk of complications. However, remember that rifampin, you always want to check drug interactions. Now, in some cases, some patients will be treated with Septra as a third agent, particularly if they have more severe disease, and some will add Septra as a third agent. Now, how about complicated disease? In this case, you want to treat longer than 6 weeks, generally want to treat for 12 weeks or longer, and these are the patients, again, with bone disease, with NeuroBrucellosis, with endocarditis, or if they have a localized suppurative infection. And in these patients, you tend to want to use at least 3 drugs, and one of those should typically be a parenteral agent. Someone with spondylitis, typically doxy and an aminoglycoside like streptomycin is preferred, and a lot of these patients will need surgical involvement as well. Obviously, if you have somebody with an osteomyelitis or a spondylitis and you don't consider surgical debridement, the patient may be at higher risk for a chronic infection. Now, NeuroBrucellosis, these are the patients who get an encephalitis or meningitis related to Brucella. 2 or 3 drugs are recommended, and you want to make sure that they have good CNS penetration. and typically doxy, rifampin, ceftriaxone, or Septra are used. And these patients require treatment for several months based upon clinical response and how well they do with normalization of their CSF parameters. And the use of steroids in NeuroBrucellosis is unclear. Endocarditis, as I said, doesn't occur that often, but it tends to have the highest mortality. Sometimes these patients will need surgical debridement of their valve or valve replacement, and typically 3 agents are recommended, and treatment can be up to 6 months. It's not well standardized after their valve is replaced, how long therapy needs to be continued. Okay, so these are some other considerations for the treatment of brucellosis. Someone who has a Brucella case maybe in the laboratory is not aware that they've been exposed. Post-exposure prophylaxis is definitely indicated for those patients, so consider post-exposure prophylaxis in healthcare workers who may have been exposed, maybe someone in the lab who's not aware that they're dealing with Brucella. There's a variety of different preventative strategies for brucellosis, like vaccinating domestic livestock. There is a vaccine for Brucella among livestock and agricultural animals. Unfortunately, there's no vaccine for humans, but there is one for livestock. Quarantining of herds is also advised if there's an outbreak of Brucella. Sometimes infected animals are slaughtered to prevent a further outbreak. And slaughterhouse workers should be protected with protective clothing and use of disinfectants. And pasteurization of milk also obviously is a chief strategy. If you have unpasteurized milk, you have to worry about Brucella as well. So in summary, again, brucellosis, a worldwide zoonotic infection, typically transmitted through food products, especially with fluids from infected animals. Think about both the acute and chronic manifestations of brucellosis, but remember it is an insidious infection that can come on over several weeks and present as an FUO. Remember the genitourinary systems with orchitis and epididymitis, the musculoskeletal compartment with skeletal disease. Remember endocarditis as a rare complication, and remember hepatitis as in the differential. Remember that combination therapy is always advised. 2 drugs generally for uncomplicated disease, typically doxyrifampin if it's really uncomplicated. If it's more complicated, think about doxy plus an aminoglycoside. 3-drug therapy is useful for serious disease like neurological disease like meningitis, encephalitis, and endocarditis. And remember the role of surgery, particularly for cardiac disease and for bone disease. And there's a variety of prevention strategies to help control Brucella in livestock. So it's not a disease you're likely going to see a lot in your careers, but it definitely does appear on the boards, and you'll probably come across a case or 2 in your careers if you know to ask the right history, to suspect it, and you know the basics. So, and remember undulant fever, I think that does get placed on boards quite a bit. So with that, I'll go ahead and stop, and thank you for your time. And in closing, I'd like to acknowledge these reference sources that were the basis for this presentation. Thank you.